Okay, so today we're going to be talking about asthma immunology here. Let me get the last couple of people admitted. All right. Okay, so I have no disclosures. Let's get this up here. And again, if anybody who just joined, please be reminded to just mute your microphone so that we don't get any feedback. Thank you. All right, so the objectives for today is going to be to discuss the differential diagnosis of common respiratory symptoms in athletes. We're going to do a brief review of asthma. Most of us have come into contact with patients with asthma, but asthma symptoms, severity, diagnosis, and treatment. We're going to highlight the pathophysiology, diagnostic testing, and treatment for exercise-induced bronchospasm, which can sometimes be thought of as the same as asthma or exercise-induced asthma. There are people with underlying asthma and then separately exercise-induced bronchospasm or both. So we'll talk about the differences between those. We're going to learn more about conditions that mimic exercise-induced bronchospasm, or EIB, as I'll refer to it during the lecture, and their respective treatments. And then we'll explain the symptoms, diagnosis, and treatment of EIB, exercise-induced anaphylaxis, so EIA, as well as angioedema, cholinergic urticaria, and then allergic rhinitis to end it. All right, so first thing I want to sort of draw your attention to is that not all respiratory symptoms are equal. So a lot of times when we have athletes come in at the beginning of the season, we are doing cardiac screening, ECGs, those sorts of things prior to, in addition with cardiac screening questions and things like that. So we can be fairly reassured going into the season that people's cardiovascular health has been adequately reviewed. However, there are still some cardiac things that we miss. So I think when we're thinking about respiratory symptoms, things like shortness of breath, wheezing, cough, chest pain, chest tightness, we can be thinking about the pulmonary system being involved. But in addition, we also have to be thinking about other systems in our body that can present in similar ways. Some clarifying questions that I typically try to ask are, are your symptoms worse than peers? Oftentimes when patients return, when players return back to their respective sports from being home all summer, or depending on how their exercise regimens were going, they may be doing more than they were previously doing. So the question is, are your symptoms worse than your peers? Is everyone just tired right now because we've kind of been slacking a little bit on workouts at home, or are you kind of the only one that's standing out? As far as timing, are symptoms happening at rest, or are they happening with or low intensity exercise? Are they happening with strenuous exercise? That gives us some information as well. Other things, and this usually is included some in the cardiac questionnaire, but do symptoms make you stop exercising? Are you able to keep pushing through, or are these symptoms such that you really can't do much of your workouts at all? Are you experiencing any recent stresses? Sometimes we see shortness of breath and chest tightness in people who have underlying anxiety, and so we're then checking in on their, those GAD-7 anxiety questionnaires, their PHQ-9. I mean, these are things we're including in sort of the workup for this. And then the other question that I always ask is, if you're short of breath, have you ever needed an inhaler when when you were sick? Just knowing kind of what people's baselines are helpful. As far as investigations and testing, I mean, things that I already mentioned were we're starting off the year getting ECGs on people. Also in our endurance and running athletes, we're usually getting hemoglobins or ferritin testing, things like that can sort of mimic people having issues that are pulmonary in nature that could be actually metabolic. Additionally, depending on how people's symptoms are presenting, we're then incorporating things like spirometry, chest x-ray, other things to sort of work this up. The big sort of goal through all of this is to rule out life-threatening things. And so for the purpose of this talk, we're going to focus more on the respiratory, the pulmonary system, but I do want to again mention that there are many ways that a lot of different things that are not related to the heart or the lungs specifically that can present. I mean, coughing can be reflux in athletes. I've seen that. So there's a lot of things on the differential, but we'll focus just on respiratory things for today. All right, so asthma. So asthma is, in 10 to 20% of our athletes that are at the elite level. And so this is seen pretty frequently. Um, what I want to point out is sort of just because patients have asthma doesn't mean they're not able to do high level things. And so I kind of have this is kind of, if you Google, the top athletes with asthma, I mean, some of these people may look familiar, but you have, starting in the top left, you have Jackie Joyner-Kersee, Olympic gold medal track and field, heptathlete. You have Jerome Bettis, or the Bus, who's in the top middle there, Super Bowl, Pro Bowl. Football player, you got David Beckham, multiple World Cups appearances and titles. Um, you got Paul Radcliffe, a British marathon runner. Bottom middle, you have like Peter Vandekay, who was with Michael Phelps when he won gold medal. And then bottom right, you have a swimming and diving legend, Greg Louganis. So, people can play at high levels with these. And so just because players have made it to Division I level athletics doesn't mean we have to assume that we have to assume some management of their illnesses, but a lot of times they're working out at higher levels than they ever have before. And so we really have to pay attention to people's underlying histories and get as much as we can out of athletes, because sometimes we're seeing them where it's exacerbated the most that it's ever been. So a little overview. So asthma, as we know, is caused by hyperactive T lymphocytes, essentially just a ramp up of your immune cells, the eosinophils, the neutrophils, the mast cells, epithelial cells, usually triggered by, in the winter, URIs. So there are times athletes say, I've may or may not have had a diagnosis of asthma when I was younger, but they get a bio-URI and suddenly they're having wheezing and coughing and symptoms that are consistent with an asthma exacerbation. Cigarette smoke, exercise, so the athletes that are outside with dust and pollens, emotion, stress, laughter, temperature changes. The other thing, the kind of bigger thing is also genetic, so internal factors, things like parents, 3 to 6 times likelier for people to have asthma if their parents have asthma, and having extra circulating levels of IgE can tend to make people more hyperactive as well. So I put this slide on here because many athletes think that they're superheroes sometimes. So they'll come in, they have these underlying issues of asthma, and they've essentially, ever since they were little, up until the point where you're seeing them, every time they're sick, they have to have an inhaler. And they never tell you anything about this on their pre-screen, and you know nothing about it until it comes up and they show in your office, and they're presenting like an asthmatic, and you're just a little baffled by why it is. And so it really is important to get good histories from them. In addition, athletes will hide a lot of things from you. So I think it's important to say questions like, have you ever needed an inhaler for anything? And have you ever, because when I ask questions like that versus like, if you have asthma, I tend to get better responses, and responses that can help me manage them versus just, do you have a diagnosis of asthma? So if we were going to make a diagnosis of asthma, we do it based on severity. So a lot of people have probably seen this chart before, but there are many components to this. So it's based on symptoms, nighttime awakenings, how much you're using your beta agonist, so your albuterol rescue inhaler, and activity limitations. So there's sometimes people have intermittent asthma or mild asthma, and it's not causing them much limitation at all. As I mentioned, though, some athletes are working out as hard as they've ever worked out before, and maybe they weren't having any exacerbations, and now they're having a lot more. It has to do with lung function, so that's on spirometry, formal spirometry testing. And then another gauge is, one question I ask any athlete or any patient I'm seeing, even in family medicine clinic with asthma, is how long ago were you on steroids? A lot of times we manage asthma with either adding on an inhaled corticosteroid, or we may be adding on, a oral steroid for them. So knowing how long it has been since they've needed that is always helpful as well. Looking more into treatment, I think, it sort of goes in a stepwise function. Again, this is a chart that many people have seen before. So stepwise, we're starting with just mild or even mild intermittent asthma, where maybe you're just needing an inhaler, kind of as needed. And then we step all the way up to needing a long-acting beta agonist with high dose inhaled steroid. And usually, at this point in step 5 or 6, we're usually seeing people in this is considered the severe persistent asthma, we're seeing them needing a lot of times allergy shots or shots of disease modifying medications to help with their immune system. So really to dampen that immune system response. But there's a lot of variations of this. We're usually not seeing people in the stage 5 to 6, usually the 1 through 4 range, but it is possible. So moving more into the concept of exercise bronchospasm. So this is synonymous with exercise-induced asthma. So I want you to think about exercise-induced bronchospasm as exercise-induced asthma. It's similar in the sense that like people will use them interchangeably, but to make sure that you're not confusing underlying asthma, with just asthma that's exercise induced, or this exercise-induced bronchospasm, I want you to think about them separately in that way. So we'll call it EIB from this point moving forward. All right, so EIB, what is it? So I want you to think about it kind of as, well, I guess to start, the way people typically are presenting with EIB is that they have a post-exercise cough, wheeze, chest pain, and there's a typo there, but shortness of breath from bronchoconstriction. This usually starts within minutes of stopping exercise. It's important to know if patients are having symptoms while exercise, during exercise, coughing, wheezing, shortness of breath, this is more consistent with a different diagnosis and not this EIB specifically. EIB is typically maxed out about 5 to 10 minutes after, and it usually is resolved within 30 minutes. An important thing to note from this is that if patients are able to, if they have another workout within this refractory period, it's a period between when their initial symptoms stop until about 4 hours after. If they do another exercise at that point, they're usually either not going to have symptoms or going to have much less symptoms than they did with the previous episode. However, in this late phase, at about the 4-hour mark after their exacerbation, they can have symptoms that return again. It has been documented that NSAIDs are actually a good way to inhibit this late phase. So if people were to take anti-inflammatory, a dose of an anti-inflammatory, it prevents that potential late phase symptoms that occur at about the 4 to 12-hour mark. The sort of pathophysiology from this, and it can be, cold air, that's a trigger, winter weather. For swimmers, it tends to be the chlorine gases. For runners, pollen smoke, other things like that, that essentially cause the smooth muscle hypertrophy within the lumen of the bronchioles. And this ends up causing a spasm. Now, I'll talk a little bit more about sort of how this works on the next slide. But just think about when you're exercising, you're usually pushing, if you're running like an endurance athlete, you're pulling about 200 liters per minute of oxygen through your system. And so that's a lot of opportunity for if your airways are not completely open, or if their muscles are hypertrophied, it's really going to cause quite a bit of strain on your airway system. So more pathophysiology wise, there's two sort of theories behind why this happens. So the first theory is that this osmotic theory, and it's essentially saying that as water is lost with evaporation and you're hyperventilating, it increases the dehydration of the mucosa inside the lining of your lungs. This causes tissue changes and inflammation, causes our mast cells to go haywire, and they release a lot of modulators that cause inflammation. With the dehydration of that mucosa, you're also getting high levels of sodium, chloride, calcium, potassium, and with all of that kind of going on, you end up getting a contraction of your smooth muscles. This causes edema and vascular leakage. And so this edema is essentially what's causing that constriction. And usually, again, this is presenting after people have stopped exercise. The thermal theory is more along the lines of, and this is to the left side of the page, but the mucosa inside your lungs cooling. And with cool air, that's a trigger for the vessels to vasoconstrict, because the vessels inside your lung, when they're feeling cold air, they want to vasoconstrict to conserve heat. And with doing that, you end up getting increased pressure inside your vascular system. You start getting vessel enlargement and engorgement, and then that vascular leakage happens again with edema. Um, Typically, the reason why, and I'm sure you're wondering at this point, why is this not happening when you're exercising? So we have enough circulating catecholamines, and specifically adrenaline and noradrenaline, that help to protect our airways during exercise. So they actually function, catecholamines function as bronchodilators. So they are constantly, as long as your adrenaline is up, you are protecting your airways from having this bronchoconstriction because they bronchodilate. So how are we getting to this diagnosis of EIB? So typically, if people are having symptoms suggestive of EIB, we're typically doing a spirometry test for them. And so with spirometry, if the spirometry test is abnormal, then we're usually treating for EIB plus or minus asthma, depending on what their spirometry results show. And that's one category of people. We can talk about how we manage that. We've talked a little bit about management of asthma, but we'll talk about treatment for EIB. If spirometry results are normal, then we talk about, is this person a high level athlete or not? If they are a high level athlete and they're going to be, if this wasn't a one-time event, if people are going to need, consistently to be using their cardiovascular system to exercise, depending on the type of exercise they do, we do these bronchial provocation tests, which I will show you in just a second how those work. The results of these tests, if they're normal, we're considering that this is not the diagnosis, but if they're abnormal, this is how we're getting this diagnosis of EIB, these bronchial or these provocation testing. If patients are not an elite athlete, or if they're not really, doing a lot of exercise and it's just kind of occasional symptoms, then sometimes what we'll do is we'll initiate a trial of a short-acting beta-2 agonist, and we'll do it about 15 to 30 minutes before exercise. If that works for people, we typically will stop there. We'll say, okay, they got the response we wanted, and we know that before, this person exercises, they're going to use this inhaler 15 to 30 minutes before. If they don't get a response from that, then you end up in the branch where you're doing this bronchial provocation testing. So it can just vary a little bit. As far as these, the tests for these, so the gold standard tests for testing for EIB is this EUCAPNIC voluntary hyperapnea test. And what happens is the patient hyperventilates into a mixture of cold, dry air, and spirometry is performed before or after hyperventilation. This is the gold standard test. It is both sensitive and specific for EIB. It's a pretty expensive test, and it can vary on availability depending on where you are. But if you're able to have that, that is the gold standard. There are other sort of tests that you can do as well. The other ones that are the most sensitive and specific for EIB are the mannitol and the hypertonic saline tests. And essentially, in both of those tests, the patient is given a nebulized either hypertonic saline or mannitol, and that is causing, again, this hyperventilation response. And spirometry is determining, whether a patient has it or not. And I'll talk about the numbers to know whether they have it or not. But that's both sensitive and specific. The other tests that you may hear about that happen are things like the methylcholine challenge, which is really not as sensitive, or it's very sensitive, just for any hypersensitivity reaction. So the methylcholine challenge is not specific for EIB or asthma or anything else. It is really non-specific for EIB. So that's not the test you want. And then any sort of lab exercise challenges, it can vary on the result you're getting depending on the level of VO2 capacity of an athlete. So I think that can vary a lot. But these other tests, the mannitol, the hypertonic saline, and the EUCAPNIC tests are the best tests for this. So moving on to sort of what are we looking at in these tests? So in general, our outcome measure is we're looking at pre and post exercise FEV1. FEV1, or this forced expiratory volume in 1 second, tends to tell us what we need to know as far as the bronchoconstriction that's happening in your lungs. And so diagnosis is based on either the severity of the FEV1 fall that happens pre or post, or the dose of the agent needed to cause the fall. So in mannitol or hypertonic saline, we're looking at the dose of those things that's needed to cause the fall. And we're also looking in the change from baseline. So as you can see in the chart, for the eucapnic test, you're looking at an FEV1 that decreases by 10%. Hypertonic saline is more on the 15% range. So those are the sort of things you're looking at. So I have an example of the eucapnic test here. Give me one second. I'll show you what it looks like. It's actually pretty interesting, and it looks like a lot of work. So this is at Kent University.
So anyone who has any respiratory issues,
so I'll play this little video for you guys.
To check them out. So we offer specific tests for exercise-induced asthma, and we also offer specific assessments and training for anyone who has dysfunctional breathing during exercise. So the EVH challenge is the challenge that we have at the Respiratory Centre for testing individuals for exercise-induced asthma. It's a very sensitive and it's a very specific test. So the EVH test itself involves a measurement of baseline lung function. So we'll measure how well you can breathe air out and how fast you can breathe out. And we'll also take a global measure of your airway information, which gives us a mark of how much information is going on inside of your airway.
We're not seeing the YouTube.
Done that, we'll ask you to actually hyperventilate.
Ooh, I was just told you guys couldn't see the video. Sorry about that, you guys. Well, the video just shows thanks for letting me know that. The video just shows someone doing the eucapnic test. You're certainly welcome to look at that on your own. So typical sports where we see EIB are, and where it commonly presents, are middle distance running, long distance, cross-country skiing, figure skating, swimming for the reasons about chlorine, like I talked about, aerobics, cycling, dancing, basketball, soccer, rugby. So those are the main sports where you're usually seeing this. So how are we managing this? So for non-pharmacological treatment, typically we're doing things like masks. Masks tend to capture heat in water and make it so your airways are not getting that cold sensation and bronchoconstricting. You're just sort of re-inhaling what you already have there. You avoid, or typically trying to avoid nose breathing. Nose breathing, people think, well, if I don't breathe out of my mouth, my lungs aren't cooling off, or you're not having that response that you're usually having with hyperventilation. But it does end up causing some nasal congestion, some sneezing, some increased secretion. So just solo nose breathing can actually make this a little bit worse. So you do want to sort of try to balance that. You can also try to do, an adequate warm up. It's been shown that having a submaximal work and doing some short sprints in the beginning before a really heavy aerobic activity can really increase your bronchial blood flow and oxygen delivery prior to exercise. As far as adjusting training durations and intensities, so you completely trying to change everything about the actual aerobic work that you're doing, it tends not to change the degree of EIB. As far as pharmacological treatments go, so cromolyn and netochromil are usually the mainstay treatment. And these are typically given before exercise, so 5 to 10 minutes before exercise. Additionally, things like leukotriene inhibitors, as we know, leukotrienes really help to exacerbate inflammatory response that you're having in your lungs. So these are things like Singulair would be an example of that. It's something you can give pre-exercise. Also, there's some small studies on fish oil, having a low sodium diet, and also vitamin C as protectors for this. As far as post-exercise goes, beta-2 agonists, short acting tends to be what you're wanting to use, and especially when you know this thing is going to onset within 5 minutes of you stopping exercise. Just know that beta agonists take about 5 minutes to start working, so that would probably need to happen sort of immediately after exercise. And then the NSAIDs, as I mentioned, can stop that latent phase peak of your symptoms again that happens 4 to 12 hours after your exercise. People with underlying asthma, we talked about management of asthma. These people need to be on, usually if they have both of these, they need to be on a low dose inhaled steroid, in addition to having a beta agonist that they're using pre-exercise, and sometimes even post-exercise as well. So EIB mimics, so things that look similar to EIB are things like vocal cord dysfunction. So you'll notice in that people are usually worse during exercise, and usually are resolving within 5 minutes of cessation. So that alone makes it different than EIB because it's happening during and not after exercise. It's often not reproducible. Typically, people are saying that they're having throat tightness, choking. They may even have some stridor. Their symptoms appear to be usually in the throat, which sort of makes sense where your vocal cords are, versus chest tightness with EIB. And typically, people tend to be normal at rest. But the mainstay treatment to see, or mainstay test to see if people have vocal cord dysfunction, is usually having a laryngoscopy to go down and look at and have challenge tests with laryngoscopy to see how if their vocal cords are spasming. The treatment for this is typically speech therapy and sort of controlling those vocal cord movements. The other thing people can get with exercise are things called hyperventilation. Hyperventilation tends to be, again, worse during exercise. It's usually resolving within 5 minutes of cessation. Again, it's often not reproducible. They're, again, talking more throat symptoms and dyspnea versus more chest symptoms with EIB. And these hyperventilation patients typically are having spirometry that is normal. So think about this: if you get normal spirometry back, and so that's something to consider. And additionally, symptoms outside of exercise, they're usually not having. So with vocal cord dysfunction and hyperventilation, no symptoms outside of exercise. With EIB, they could have it. And so with hyperventilation, the treatment of that is breathing techniques, some psychology actually sometimes, just with people being anxious potentially is causing hyperventilation with exercise, and then working on abdominal muscle breathing specifically. So exercise-induced urticaria. So, this is sort of an example you can see here on the person's arm in this picture. We'll sort of move and talk about sort of symptoms that people present with. So people are usually presenting with things like warmth, itching. Sometimes they'll have a little swelling in their mouth, but they're usually having like a lot of itching, and um, 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 potentially they can have vascular collapse. It is rare, but they are feeling like there is some obstruction that's going on in the setting of like feeling warm and itchy. Usually people that are experiencing this have a history of atopy, so asthma, eczema, those type of atopic conditions, or a family history of atopy. This could be secondary to types of foods they're eating before exercising. Also could be due to weather, like humid weather tends to pull this out. And additionally, NSAIDs and aspirin can cause this and or exacerbate patients who have this. So exercise modifications are sort of the mainstay of this. One sort of take home from this exercise-induced anaphylaxis is that there is no prophylaxis for this. And so if patients tell me that they're, itching during exercise, or they're having, swelling of their mouth, I always want to know, did they pass out? What did they have to do to manage their symptoms? That sort of thing. Some patients know that this can happen and they carry around an EpiPen. And so the goal is going to be to decrease intensity of your exercise. So you may have to do shorter spurts of less intensity, avoiding exercise on hot, humid days. Stop exercising at the first sign of itching. So a lot of times people are not getting to this vascular collapse and complete anaphylaxis if they can sort of stop when they're first starting to itch. And this can be kind of hard if you imagine if an athlete has this, but avoid eating 4 hours before exercise. I think maybe for someone who's not an elite or high level athlete, that may be possible, but I think for athletes that would be pretty hard. For management, things like epinephrine, antihistamines, so your typical H2 or H1 allergy medicines, or cromolyn as well can be helpful for treatment of this as well. I would treat this, if somebody has this as an emergency, so you can give them some of these medications, but they definitely deserve a trip to the emergency room in case they do have vascular collapse. The next thing on the list is cholinergic urticaria. I actually personally have this, and I can say that this is pretty miserable. It doesn't happen always for, if people have this as an underlying condition, it doesn't happen with with all exercise, but it can sort of vary. So the pathophysiology of this is essentially an exaggerated cholinergic response to a rapid elevation in core body temperature. So I find that I tend to have this if I just leave my house and just start running and don't do like any sort of warm-ups before that. Also, people tend to have this in more like humid or hot weather where their core body temperature rises pretty quickly. Typically, people with underlying anxiety can have this. People who are for some reason taking hot showers before exercising, that can also exacerbate this as well. People are usually getting flushing. They're getting these actual urticaria papules. So not just like with the anaphylaxis where they're getting itching, they're actually able to see wheals and papules on their body, and it usually happens within 10 minutes of exercise. If you think also about just this dumbbells mnemonic that you used in medical school, probably the diarrhea, the urination, these are other manifestations. They're more rare, but people can get abdominal pain, salivation, diarrhea, lacrimation, and even pass out from this as well. So the treatments for this is usually hydroxyzine. So there are some people who just take this daily hydroxyzine. Sometimes they take it on the day that they're going to exercise. You also can take something called ciprofloxacin, which is also helps with your allergic response to this. In addition, I personally actually take just a daily, like I'll take a Zyrtec or an H2 antihistamine prior to running, usually about a half hour prior to running, and that seems to help as well. All right, so the last thing is exercise-induced angioedema. And so I want to point out that this is non-itchy. So you're not having any itching at all, but this is just swelling of the facial region and sometimes in the throat area, but it can be anywhere on the body, but it's swelling that you're getting with exercise. The prevention for this is modification of your exercise program. And in addition, things like H2 antihistamines or even cimetidine, which we know are H2 medicines that we use in our GI system, those can also be used to prevent this as well. But again, this is non-itchy facial swelling. So if you have itchy facial swelling, that's more along the lines of exercise-induced urticaria, which can lead into anaphylaxis. So that's an important note there. All right, so I have a few review questions. I'll open up the chat if anybody wants to chime in. There's 3 of them, so we'll roll through them and kind of go from there. So the first question is for exercise-induced anaphylaxis. You guys can kind of read through that and let me know your thoughts. You're welcome to chime in on the chat. All right, and so the answer to the first question is B. So exercise-induced anaphylaxis is due to that mast cell degranulation, which we talked about. We know that this can be fatal if it's left untreated. So certainly paying attention to people who are presenting, and people may stop themselves from exercising prior to having the full-blown anaphylaxis and vascular collapse. So it's important to get people's full history on this as well. So next question is, we have a 16-year-old cross-country skier who presents with mother for management of her exercise-induced bronchospasm. She has not been diagnosed with asthma and has been managed with an inhaled beta-2 agonist prior to exercise, along with proper warm-up. Unfortunately, she's still experiencing chest tightness and wheezing when racing, and it's affecting her participation. Her mom wants to know what else can be done. Which of the following is the next best step in management? And so the answer to this one is going to be D. So this is an example of exercise-induced bronchospasm, or EIB. You already have the diagnosis there. Because she doesn't have likely underlying asthma, the beta 2 prior to exercise is usually not going to help people unless they have underlying asthma. So really what you're wanting to do is something like a cromolyn, and that's going to be 15 minutes before exercise. So she'll be treated like an isolated EIB. Let's see. All right, last question. In order to prevent exercise-induced bronchospasm during competition, athletes with documented asthma would benefit from the following treatments. All right. So the answer to this one is A. So we usually are pre-medicating with beta agonists, and these are in people with documented underlying asthma. We're usually doing that and not isolated. I'm going to answer just a quick question here from Dr. O'Kane. Let's see. You mentioned the response to short-acting beta agonists can be. So I'm going to read this question for you guys. So you mentioned that the response to short-acting beta agonists can be diagnosis and treatment for EIB. In treatment, though, you recommend beta agonists as post-exercise treatment. Do you recommend short-acting beta agonists prior to exercise for EIB? So EIB with underlying asthma, you can treat these patients with a short-acting beta agonist. The mainstay treatment for EIB, like alone without underlying asthma, is something like cromolyn or singular prior to them working out 10 to 15 minutes. Additionally, if they have underlying asthma, a pre-workout beta agonist is okay to add in addition. Let's see. And then a short-acting beta agonist can be pre and post-treatment for EIB in patients with underlying asthma. Outside of that, the short-acting beta agonist does not have a role unless it's more, so the question is, previously I had a chart that demonstrated, and I'll actually go back to that for a second. I understand the question here. So in the chart here, it talks about ways that you can diagnose EIB. And so typically if people are having, if they have normal spirometry testing, then you kind of have two pathways. Usually if they're an elite athlete, the reason it says elite athlete is like elite athletes are going to have the most resources as far as getting these bronchial provocation testing completed. They're also going to need an answer a lot faster, and they're going to be performing at a higher level more frequently. Sometimes this happens in patients who don't really do a high level of exercise, or they don't have the resources to pay for a bronchial provocation test because they can be very, very expensive. And so what will happen in those cases is that patients are given an initial trial of a short-acting beta agonist 15 to 30 minutes before exercise. And if that works, then we're going to continue treatment, and we're going to say that those people likely have some underlying asthma. If that for some reason does not work, then we're performing the bronchial provocation testing that is then probably going to be covered by insurance, and we're getting that formal diagnosis of EIB. Hopefully that answered your question. Any other questions? You guys are feel free to write in the chat box if you do. All right, I think I'll cut the presentation off there. Thank you to everyone who joined, and feel free to email me. I think let me pull my email back up here. Feel free to email me with any questions that you guys have.